All right, let's go ahead and get started. Welcome everyone to our UMTRC webinar for today. I'm going to go over just a little bit of housekeeping before we get started. My name is Becky Sanders. I'm the Program Director for the Upper Midwest Telehealth Resource Center. During today's webinar, we encourage you to ask questions in the Q&A box, that you'll see the link to that in the bottom of your screen. That way we can, if there's any questions that we can't get to during the webinar, we have those afterwards and we can follow up with you. We will be doing a survey at the end, and then also towards the end a little check-in as we are trying to increase the efficacy of our webinars and bring you guys the topics that you'd like to hear about. The attendees are in listen-only mode for today. We will be recording today's webinar. It will be posted on our UMTRC YouTube page by the end of the week, and also a link with the slides and a link to that recording will be posted on our umtrc.org website under archived webinars. So without further ado, I'm going to go ahead and introduce our speaker for today. We are very pleased to have Billi Jo, excuse me, Billi Jo Hennika with us today. She is the Chief Operating Officer and Accountable Care Organization Champion at McKenzie Health in Sandusky, Michigan. She's been with them for several years and previously had directed 6 family practice offices. As an ACO champion, she focuses on population health management and has a great understanding of the needs of their community and the lack of services that are available to them. So at this point, Billi Jo, I'm going to hand it over to you.
All right. Thank you, Becky, and thank you for having me today. So improving access with virtual care, McKenzie has been working in the virtual environment for several years, and we'd like to share that experience that we've had and the success. Just a little bit of history about McKenzie Health System. We are a 25-bed critical access hospital in Sanilac County. Sanilac County is our main service area, and that is around 42,000 people. We provide services such as surgical services, both inpatient and outpatient, as well as swing bed. And for those of you who are not familiar with critical access hospitals and swing bed, that would be similar to a skilled nursing facility. And looking more towards McKenzie focuses on short stay patients and getting them back into their original environment. We do provide inpatient services. We do own our own EMS service, and as well as a retail pharmacist. Inpatient and outpatient rehab, diagnostic imaging, lab, cardiopulmonary. Our emergency department services around 6,000 visits annually. We are acute stroke ready certified, AHAR certified. We are a level 4 trauma center. We are geriatric certified, and we are an oxy-free ED. In addition, McKenzie has several primary care providers. We actually have 6 clinics in surrounding towns that are throughout Sanilac County, and that consists of 4 physicians, 8 advanced practice practitioners, and all of those are patient-centered medical home certified through Blue Cross and Blue Shield, and we've implemented an after-hours sick visit clinic that we'll talk about a little bit later. Specialty services that are offered, we do employ an orthopedic surgeon, and outside of that we do have multiple visiting providers that either rent space or participate via surgical services and on a hospital basis. And we are part of an accountable care organization. We were one of the first pioneer rural ACOs in 2014. We have been through 3 ACOs now. And a lot of what we've learned has focused on, again, managing that population and how virtual care can help with that. The mission at McKenzie Health System, as we lead in transforming how healthcare is designed and delivered, we emphasize in clinical and service excellence and promote access to affordable care. We're accomplishing this through the combined efforts of our healthcare team and partnerships with the community and other healthcare systems. I think it's important to mention our mission here because everything that we've done that's led us to telehealth and virtual care has been aligned with our mission. And I think as all of you take a look at your mission, that you would find in some way it would also align with providing this type of care. So the hope today is that when you're finished with this presentation, that you have a good understanding of what virtual care can do for your community, how potentially to get buy-in from providers, staff, and patients if you're struggling with that, as well as I did add to my presentation leadership and the board if that is someone that your organization is dealing with. And then types of virtual care and what is best for your organization. So really going through that organizational assessment that was beneficial for McKenzie. Just to start out, a couple definitions that I think are pretty important as we talk about telehealth and telemedicine. I utilized the definition from the Department of Health and Human Services. If you've done any research on this, you are well aware that there are multiple definitions and some group them together and some do not. But in the eyes of Health and Human Services, telehealth and telemedicine are used together, the use of electronic information and telecommunication technologies to support and promote long-distance clinical care, patient and professional health related education, and public health and health administration. The two specific types, synchronous and asynchronous definitions, are listed there. I think it's important to know that. And within your organization, if you are implemented or have already implemented any of these services, we've found great benefit in defining what our definition of these are. Because of the varying, depending on the entities, it did clarify for a lot of staff when we said telehealth or telemedicine, do they mean something different in our organization, or are we utilizing them the same? And so be sure to have a policy that defines those definitions. So starting with an organizational evaluation, as we think about virtual care and what is the first step, and taking a look, let's take a look at our organization. What services are already offered locally, and are they sustainable? Would telehealth improve the service? And when we talk about services or evaluating, it doesn't necessarily have to be a service that you provide internally. It could be a competitor that provides it. And is it really meeting the needs of your community? Are you finding that availability isn't there? Are you finding that there is not enough access for that service? And so adding in addition would be important. And as you start this evaluation project, I think that one of the #1 things is having somebody who's really good at taking notes on what you're learning and what you're finding, because in the end, when we look at making a decision at whether telehealth is the right thing for your community or your organization, those notes will help to guide you. So secondly, as we evaluate the organization, take a look at the data that you have. Things that McKenzie utilized was ED and inpatient transfer logs. We took a look at the diagnoses of those that are being transferred out from both the ED and inpatient. Were they needed to go to a higher level of care? Do we not have the specialist available? Was it the patient choice of why we had transferred the patient? And then really, when you find the answers to those questions, take a look at, can you support the service in keeping the patient there if you provided it? An example may be, do you have cardiopulmonary services 24/7? So if you did have a cardiologist that was on site and you needed to provide some advanced treatments, would you be able to provide that, or would it require additional equipment within the facility? Again, part of the evaluation process. And then another important thing that I think is often forgotten is utilization of services by diagnosis from the hospital and clinic perspective. So when we look at the ED, we look at inpatient transfers, that seems pretty straightforward, but why else are people utilizing our services? What are the diagnoses for those people that are coming in and having labs drawn, that are having other diagnostic imaging services, cardiopulmonary? I think what we find is people will utilize, at least in our rural community, that they may not be a part of our primary care, but they do come to the hospital to seek those types of services such as lab and diagnostic imaging. So make sure you take a look at those too, because it might be a good indication where you otherwise wouldn't. And then of course, where your primary care, what diagnoses they're seeing. In addition, external data showing utilization of services outside of your organization. I previously mentioned that we've been part of an accountable care organization since 2014, and this gives us access to a lot of information that we otherwise wouldn't. We get CMS claims data that we're able to look at for those patients that are attributed to us, and we're able to see where they've been, whether it's a McKenzie provider, a McKenzie outpatient service, or whether they're utilizing all their services in Florida when they're there, because we do have a lot of patients that travel back and forth. And so it really helps to show patients traveling that maybe don't report back to primary. It just gives a lot of good information. And so the accountable care organization, all of that information, if you are not part of one and don't have access, we do find that some insurance carriers, at least in the Michigan area, you're able to get in-network and out-of-network utilization, but maybe not specifically what providers they're going to. So depending on where you're, what state that you're from and what that information looks like, sometimes that's a good place to start too. A few years ago, prior to being in the accountable care organization, we did have the ability to purchase market share data for the state. And so that would show by zip code where your patients are seeking orthopedic or any specialty. And so prior to the ACO data, that was very helpful. And so something you might want to consider for your organization if you don't already get that information. Another important part, so we've talked about things that we can pull from data sources, so where people are utilizing things, but a community needs assessment or a community service. So I think that we've found that what we believe people need or want necessarily doesn't align with what they want. As a critical access hospital, we are required to complete a community needs assessment every 3 years. And that brings forth a lot of wonderful information. If you're not required or do not do a community needs assessment, consider a community survey, and maybe that's something that is available in your outpatient environment, your clinics, anywhere that you can bring in people to talk about the services that they feel or where the gaps in care are. And then when you collect that feedback, I think validation is very important, because as we validate it, it may just be that there's a lack of knowledge in the community that you provide the service. So always a lot of good information that comes out of there, validating and figure out what is the plan, add the service or add marketing so they know you have it. So a lot of information that I just talked about as you evaluate the organization and consider if telemedicine is for your organization or not. The next step, probably one of the most important, and that is to take the time to evaluate all that information. So I mentioned earlier, making sure that you engage the right stakeholders, the right person to collect all that information and organize it, because at this point, if you're anything like McKenzie's organization, we've got to have a plan, and in order to get support from the board, from leadership, from the providers, from the community, you have to have a really good plan in. And so you've got to have some data that would prove that what you're trying to implement is the right thing. And so take the time to evaluate the information, involve the right stakeholders in the conversation. So I think that's different depending on your organization and who approval needs to come from. And in the end, the question is there an identified need to implement telehealth services? And so in the assumption that there is, as I think in today's environment, telehealth is always, it's always going to be a benefit. There's going to be services that it makes sense for and some that don't, but in some fashion, there will be a benefit to it. So next step is, how do we develop it? What things do we need to know and make a decision about in order to be successful in developing the service? And so Who will provide the service? Is it a current relationship that exists with another entity? Perhaps you have a partnership with a large tertiary facility that provides a lot of specialty services, and is it something that they provide telehealth and they can extend that to your organization along with providers? Or is it something that your organization yourself will implement, employ? Important, I think, to take a look at both of those things. Budgetary purposes, all of that will be very important. And what type of telehealth services are you looking to provide? Later on, towards the end, I'll talk about the different services that McKenzie has and why we chose to implement the way that we did. But type of telehealth service, so there's, depending on your knowledge of telehealth, right now, due to COVID, there is a lot more leeway in billing as it relates to location of provider and patient and staff and what's billable to insurances. I am not an expert in billing. I certainly advise you as you're developing to bring billing along, because that seems to always get us caught up in things that we feel like are wonderful and then we can't bill for the services. But right now, the provider could be remote, the patient could be remote, and still able to bill, at least from our organization's standpoint. You may have a location where patients come and the provider is remote, or providers in the office and patients remote. So there's a lot of different options as it relates and what works for your organization or what the needs of the community are. And then again, synchronous or asynchronous, depending upon what you're trying to accomplish. And then again, that word engagement and who needs to be engaged and at what point. So I think the more people that you engage from the beginning, success will come from that, as well as identifying things that you may not have thought about, how it affects diagnostic imaging, how it affects the lab. IT, of course, always needs to come along because that is huge in the telemedicine, but even outside internet carriers, what does it look like? What's your platform for your community? Or what's future plans to connect the community if that is poor? Another large part, which answering the question before, what type of telemedicine are you looking to promote or implement, is what type of equipment are you going to need? I have robot cart here. There is a lot of different types that are available depending if you want peripherals. So there's carts that you can hook up stethoscopes to. Providers are able to visually take a look in the ears, the nose, the throat, ones that you can do ECGs on. I mean, the options are endless, and it really is pointed at what your needs are. But it's important to think about those. Budgetary wise, that is going to play a huge role in whether maybe you partner with another entity or you're able to implement it yourself. And then technical needs, that was huge here at McKenzie. Being a small rural hospital, critical access, our knowledge base for telehealth carts and peripherals, it was not there. So we definitely needed the expertise of those from larger organizations who had been doing it for a couple years and was able to pass that on to us and also able to support. So another consideration when you're thinking about partnering versus doing things on your own. And then software platforms, what are we going to utilize if we provide the telehealth service? Is it something that our EMR system provides? Is it a standalone product that we're going to have to interface? Definitely include your front end staff on that, because they will be the ones utilizing it and needs to work for them. Needs to be a smooth process. Then what types of training and education are going to be needed, at what level, what are timelines, and then marketing, of course. What are we looking at as it relates to the needs, maybe going back to the community needs assessment and finding out that there are lots of services that you provide that the community is not aware of. So again, marketing, very important. And then again, that word budgeting again. So a lot of times budgeting can make or break these projects. So taking a look at what return on investment is going to be. And I think it's important to make sure that access is included in that as well. keeping competitive, of course, with those that are in the area. That might be compelling in itself as it relates to budgeting. Buy-in. So one of I think our biggest struggles or conversations that we have today is getting buy-in from people. Telehealth seems scary. We're used to that in-person visit. And so getting engagement from the community, from really everybody, I think is something that I don't know that I've had one experience with any location where we didn't struggle with that. And so making sure, again, when we talked about getting the right stakeholders engaged from the beginning, providers and staff, most definitely, and whether that's a champion staff member or provider, definitely bring them along, because they're going to have a lot of good input, as well as having them on your team will help them to bring along everyone else. Engaging them in the evaluation process, certainly, and then educate. Again, when we finish the evaluation, we're really looking at trying to figure out, is there benefits? Are there cost efficiency? What are those things? Why do we want this program? Why is it going to work? Why will people be enticed? And so that's important when you're trying to get providers and staff to buy in, for them to understand some of the benefits. And so I listed just a few there. And again, depending on what issues you're trying to solve in your community, those will be part of the education. Pilot location, we have had great luck with utilizing pilot locations, and McKenzie has actually been a pilot location for services, not only that we have implemented in picking one provider, but also for larger organizations that have implemented some services. And again, we'll talk about that later, but definitely finding one location, working out all the bugs and making sure that you have a really good product, workflow, policy, procedure, and then rolling that out. It also helps to have a pilot location who is doing the same work as others that can speak to it, the live experience, and implemented changes as needed. The community, I can't say education, because there is a lot of fear in the community about not being able to connect, or it isn't going to be the same, or my treatment won't be as good. So education by staff when they come in, having maybe a screen in your office that's set up where you can do demos on how it's going to work, having the staff when they're there for their annual visit, show them how they'll connect, setting them up with the portal, if that's how, whatever the software and program that it is, the more that you can get patients hands-on, I think the better outcomes that you'll have with people not being afraid to utilize it. The leadership and board, or whoever that entity is that you will be reporting to or getting final approval for, use that data to prove the need. Again, looking at benefits to the community and a fiscally responsible program. So if you're looking at budget neutrality, how do you make that happen? Maybe it is as part of an accountable care organization like McKenzie. One of our biggest things is the right service at the right time. And so utilizing the emergency department when otherwise we'd be looking at an after hours clinic, shared savings and reducing cost. I might not put that to pen and paper as it is results in a financial bottom line of the program, but overall in the big scheme of things, that's fiscally responsible. So depending on what your needs are and what you're trying to accomplish, I think that putting that all down and utilizing that evaluation is helpful. I think right now we'll go ahead, and I think Becky wants to do a little survey right now. So we'll take a break and let her do that, and then I'll come back to community benefits.
Thanks so much, Billi Jo. So we are working on improving our survey process. And right now, I'm going to do a quick webinar check-in. I'm going to put this into the chat here for you guys to give us a little bit of feedback. So far in the presentation, what is your main takeaway? And then, have you learned something new so far in the presentation? If so, what was it? And then start thinking about your questions for the presenter, because we're going to have time at the end here to answer your questions. So that is our check-in for today, just those 3 questions. And Cam, are you seeing any responses yet on those?
I will give a couple minutes just to see if those responses come through. We have 1 response currently.
Okay. Please click on the link that I put in the chat and fill out the survey. We've got one that responded to in the chat that buy-in is important, and I totally agree. And that may be something we want to discuss a little bit later, Billi Jo, is what did it take to get buy-in at your facility? Anything else we want to highlight before we move on? All right, I'm going to hand things back over to you, Billi Jo. Thank you.
Thank you, Becky. So moving on to community benefits. So bringing care to your community in an outpatient setting. So focus on that first. Obviously, specialty care options close to home. I think that's invaluable to family and patients when they don't have to travel. And of course, number 2, travel reduced. At least at McKenzie, a lot of our patients struggle with travel, trying to get to appointments that are a couple hours away. We do not have a robust transportation system within our community, and so we either have family members having to take days off of work in order to get their family member there, or because we're in Michigan and we have snowstorms and that cancels an appointment. And now again, I've missed my cardiology appointment, and so definitely makes a huge difference when they do not have to travel in order to have specialty care. Improved compliance, again, I think that's self-explanatory related to the travel. Being able to get to the appointments, very important. Less waiting time when it's locally, and maybe there's a lot more opportunity and flexibility in the scheduling for the clinic because it's offered through telemedicine. And I'll talk a little bit more about that in one of the initiatives and programs that we've implemented. And then obviously COVID, this flashed in our face, is less exposure to illness from other patients. And even before COVID, the flu, many other infectious diseases that we had to deal with, and viruses, we certainly try to protect our patients and keep them away from one another when they're ill. So moving to telehealth certainly improves that. In the hospital environment, immediate evaluation in the emergency department. So if you have that specialty via telehealth and otherwise you wouldn't, you can consult and get that evaluation done in the emergency department. And that really tells us a couple of things. That specialist evaluating, can we keep them in-house and treat them here? Or is this condition beyond what a small hospital, rural hospital can handle? And we do need to transfer them to a larger tertiary facility. And then immediate intervention upon arrival at a tertiary facility. Again, this is a program that McKenzie has in place, and we've had great outcomes with that. So I will talk in detail about that when I talk about the program. Improved quality, no matter what program it is, whether it's telehealth or maybe it's one of the certifications that you have, and that's creating metrics to track. So what would I expect that it is doing, or what would I expect the outcomes would do, and what measures do I need to track to ensure that that's happening? Making sure that you continue to evaluate the program and adjust as necessary. One of the most important things is sometimes we believe that a service is necessary, and then we find that it isn't. And being able to evaluate that and make changes as necessary. So being very fluid is important. And then reduction in healthcare costs. Quality and reduction in cost in an accountable care organization are two of the factors that we found most valuable, and first and foremost is quality. You never mind spending the money if the quality is there, because in the end, it's going to should mean a reduction in overall cost, improvement in quality of life, lots of good things. So keeping an eye on those two factors. Again, there's that right service, right time. I think that we all strive for that inside of our organizations, to be able to provide that to the community. And then elimination of transfer when appropriate. Again, keeping patients in their community as often as possible, as long as possible, and whenever appropriate. Of course, challenges. There's always going to be challenges for any program. And in the rural area, internet connectivity and availability is always there. I know that there's a lot of initiatives happening currently to try to improve rural access to reliable internet connections. And so we have seen some of that in our county. I have not implemented here at McKenzie, but a solution to that at some other locations that I've spoken to, they have actually created a hotspot outside of their office so that the patient could drive into the parking lot with their own device, connect to their Wi-Fi, and connect to the provider. And so that telehealth service, preventing them from having to come into the office, from being exposed, for those patients who don't otherwise have the ability to connect. I've also heard of community libraries often offering a hotspot, as well as schools for these same types of service. So partnerships with the community, very important. And then community fear of technology. Again, education, proving to them that they can, and it is simple, with hands-on teaching. I think that's essential. Equipment, challenges with equipment, the cost of equipment, depending on what type of service that you're trying to provide, it can be very limiting. And at that point, that's when we consider partnering. There are also a ton of grants that are out there in order for us to expand these. So definitely doing the evaluation, figuring out what it is, and then what are our options on purchasing equipment, and keeping those grants in mind. Technical expertise, talked about that a little bit earlier, so I won't go into detail there. And then provider willingness to provide the service, struggle that McKenzie definitely dealt with, and again, utilizing, finding that pilot office, that one provider that has a desire and a love for what it is you're trying to implement, and having them pave the way. We've had great success for that. And then challenging in budgets. And again, applying for grants. And we found community as well will get engaged to help to make these different services happen if the budget doesn't allow for it. So I think not boxing yourself in and keeping an open mind when it comes to finding the financial means to implement services. So I earlier had talked about a couple different things that McKenzie had done, and here's really our history as it relates to telehealth services. Again, we're a 25-bed critical access hospital. We do provide a multitude of services, both inpatient and outpatient, but specialty care is a concern within our community. And when we look at where is the closest tertiary facility, we're looking at around 60 minutes. When we're looking at stroke care and actually a location that can provide immediate intervention, you're looking at more 90 to 120 minutes. So as we know, the faster that you can intervene when a stroke is occurring, the better outcomes. And so in 2011, McKenzie received was a recipient of a HRSA grant to develop a telemedicine program in rural, and did so by partnering with Ascension Health, St. John Providence Neuroscience Center of Excellence. In doing so, we were the pilot for that program, and the outcomes, we implemented a telecart, a robot at our hospital, and those neurologists From the Neuroscience Center of Excellence, we'd have a patient that come in, they would have symptoms, we'd contact the neurologist, they'd do an assessment, they would advise maybe what medications to give, what needs to occur, and then we could ship them directly into the lab for intervention. Change in outcomes for stroke patients were wonderful, and I wish I would have brought some of those stats for you, and I did not, because we do a presentation on stroke care only, and I should have integrated some of those in, but definitely huge change in stroke care outcomes. And from that, I believe now Ascension has multiple locations throughout the state that they partner with to provide this stroke care. So very great initiative, and as the pilot, we felt very strongly about it, again, wanting to improve what the services were in our community. And then in 2012, and I put to current because we're always evaluating the outpatient clinic specialty care. And again, this is provided through Ascension. So they have some of the best specialists in Michigan, access to specialists that McKenzie otherwise wouldn't. And so they have a clinic that they provide and bring in. Their specialists will connect to our network, and we schedule patients, and don't have to drive. If there was something necessary that they had to go down, they could be sent over to McKenzie for all the testing purposes, again, staying local. And then if it was something beyond what McKenzie could do, then certainly the patient still has a choice to choose what organization that they want to go to. So Psychiatry was one of the first things that we brought in an outpatient side, and that was in 2012 because there was very few available here, and it was very difficult for patients to get in, as well as the ones that were local took only select insurances, so again caused struggle for access to care for a specific population, and so they were able to close that gap for us. Between 2012 and 2015, we did implement a couple other specialty services on the outpatient side that ended up to prove to not the volume that we thought would be here, was just not here. And we're actually going to revisit one of those, and that would be pulmonology. It very well could have been in 2012, 2013 when we took a look at that. The community just wasn't ready for that type of service via telehealth, where now they're becoming more familiar with it. And so it very well, because we do show a need, that the community would take hold of that and begin to utilize it. In 2015, McKenzie invested in the technology and equipment that would allow EKGs to be sent from our ambulance directly to the emergency room physicians. We had, again, wonderful outcomes from the time from door to balloon. We are, again, 60 minutes from the closest tertiary facility, and so we have multiple instances where that EKG was taken out on the field, sent to our emergency department physician based on evaluation and interpretation of that EKG. The helicopter is landing at our location prior to the ambulance arriving. Again, rural area, we're traveling could be 30 minutes to pick up a patient at their location and get them back here. So certainly wonderful outcomes from that as well. In 2018, we implemented an after-hours sick clinic. That was part of a community needs assessment that was performed. A lot of feedback was there's not availability of after hours. And so what we had evaluated to confirm that what was on the community needs assessment was certainly aligned with data that we were. So looking at our ED, it was evident that we had a lot after hours of patients utilizing the emergency department that would be considered non-urgent, non-emergent cases. And then looking at patients that potentially were getting turned away from a provider's office because they didn't have availability to see same-day sick. So implementing, we utilized our own providers to provide the after-hours clinic. So the patient comes to the office and they are met by medical assistants trained in utilizing the technology and the robot. the provider's remote connects to them using the peripherals. They're able to listen to heart sounds, lung sounds. They control the camera so they can zoom in, and again, a device to be able to look in the eyes, ears, nose, throat, and send prescriptions electronically. So we have had a lot of wonderful outcomes with that service, as well as preventing a patient from having to drive 45, 50 minutes to the closest after hours urgent clinic. In 2019, we implemented psychiatry and social work in the hospital environment. So if you recall, back in 2012, we had brought the outpatient clinic specialty care of psychiatry, but that was not offered in the hospital environment. McKenzie has struggled for years with placement of psychiatric patients that arrive at our emergency department. There's been times when we've sat on those patients for 2-3 days, and that really is against our right service, right time for our patients, and really our hands are tied not having psychiatric professional within our organization. We were unable to get the patient the care that they needed right away. And so implementing this service we thought would be a wonderful help, providing social work from Ascension and assisting with placement. We did see a lot of benefit in the social work, but unfortunately, the psychiatrist, because social work was doing such a great job in placing them, we were underutilizing the psychiatry. So we've since discontinued psychiatry and continued with social work. So again, making sure that you're always reevaluating, very important. Change when change is needed, and not being afraid to terminate a service if it's just not working or didn't turn out to be what you thought. In 2020, at the hospital level, we've implemented pulmonology, neurology, and so previously, when we did the stroke care, the neurologists were stroke certified and they would only handle stroke cases. And so now we've expanded that into all neurology services as well as nephrology. So we have been utilizing that service thus far and hoping to see an increased growth in pulmonology need throughout the organization as it relates to re-implementing that pulmonology clinic on the outpatient side. So pulmonology was one that we started in 2012. We would not get good buy-in from the community. And now that we have patients utilizing it in the hospital environment, we're hoping that they will be more accepting of that type of service on the outpatient side. We are currently working on implementation of cardiology services via telehealth as well. Cardiac issues is one of our #1 diagnoses for transfers. And we previously did have a cardiologist service from a larger institution on site here. And due to a shortage in cardiology, they weren't able to provide it. So we've moved to looking for a telehealth solution. And then in 2020, virtual visits and primary care, something that we've been looking at for probably 2 years. COVID made us jump in. We didn't have a lot of buy-in from our providers as it relates to offering those types of visits in the clinic. So it was one of those things that the situation, it was there and providers were willing to jump in, and it's been successful. There's been challenges related to connectivity. There's been a lot of great outcomes. In this case, I can't say that buy-in, because we brought them along, although we have in the last 2 years, is what got us to implement primary care visits in our primary care clinics. It was COVID. It was patients not wanting to come in, patients' fear. And so in this case, where typically we would see that providers are ready to provide the service, but patients aren't willing to accept it, it was the exact opposite in this situation. And so patients desired it. We wanted to stay competitive. We wanted to be able to still assess patients. We wanted to be able to provide the care. And so it was a pretty easy sell at that point to the primary care providers in their commitment to their patients and yeah, it's the right time. We've got to provide this service. And so now I think we'll just open it up for questions.
Yes, thank you so much, Billi Jo. I appreciate it, and such great information. So we are going to open it up for questions. I have a couple that you brought up, a couple things that sparked some questions. So I'm going to start with buy-in process. So you've talked about buy-in and how important that is. What did that look like within your critical access hospital, and kind of who started it, and what was that process?
Well, I'll utilize one of my CEO's favorite term is drip, drip, drip. And so he has been talking about telehealth and the importance, as well as accountable care organization, for years. And I think sometimes, depending on what your medical staff looks like, what your employees look like, what they're used to, I think sometimes that is what it takes. Like, there is nobody who's going to be willing to just commit to something. It's over time that once you hear it enough, you're ready, you're committed. But creating that list of benefits and why it is you're implementing, I think that's number one. All of us know that our providers, our organization, we're here for the community to provide good health care, and it's hard to argue with. Otherwise, patients are driving 2 hours. We don't have the ability to provide stroke care, but if we use telehealth, the outcomes are magnificent. And I think these case studies that we do, it's very difficult to argue that there's not a clear benefit to these services.
Mm-hmm. Absolutely. And as you guys are listening to these questions, please feel free to use the Q&A button at the bottom of your screen and send in your own questions, and we'll work through these questions. Also, we have our survey at the end that we've put into the chat. You can click on that post survey link and start filling out the feedback for us as hosting this webinar, and also we'll send that on to Billi Jo for feedback for herself. Cam, did you have a question you wanted to ask before I go to my next question? You are muted. Nope. All right, well, maybe we'll come back to you. All right, well, he works on his audio issue. So one of the other things that you mentioned, Billi Jo, was transportation. And I just recently saw an article, we shared this on our UMTRC website and our news articles, that Lyft is partnering with Epic so that you, within your electronic medical record, if you have Epic, you could actually schedule transportation for the patient. Do you guys have Lyft and Uber up in your county?
We do not have Lyft or Uber. We have Sanilac Transportation, which runs during normal business hours. They have expanded a little bit for some scheduled after hours. We did have a taxi service that actually, and when I say taxi service, I mean one van that is a taxi service. But since COVID has started, that has it's reduced, and that service isn't no longer running. Mm-hmm. And then it's family and volunteers that will take. So again, transportation is a huge issue here. Most that run locally will not go outside of the county. And so that's where we run into specialties outside of the county. You know, there's just not an option for patients.
Yeah. I mean, you spoke about some broadband barriers too with COVID-19 and patients now in Michigan, and this is a permanent change in Michigan, that patients can be at home, if they're Medicaid patients, I should say, for telehealth. Can you talk about what broadband's like in your county?
It's very hit or miss. There are, I can't tell you the number that we would claim that has coverage, but I'll say that there's just dark holes. So you may have people that live a half a mile away from each other, and one has wonderful connectivity, and the next one, there is absolutely no connectivity. We have employees throughout the organization that live throughout the Sanilac County as well, and it will be hit or miss for them. So just even being able to receive phone calls at home via cell service for some of our employees is difficult. And then you have others that there is absolutely no problems whatsoever. So I know that our community is working on connectivity. I'm hoping that they continue and find a great solution. I think the one benefit that I will say is during some of these visits, because of COVID, that we've connected with patients via telehealth, and then connectivity couldn't be sustained, we were able to move over to a telephone visit. So that initial connection high, we were able to see faces for a couple of seconds, I think made it real for the patient, and like, oh, my provider really is here. And then having that ability to move to a telephone call was allowed us to complete the visit.
Right. You also mentioned cardiac services and neurology services, and we know that time is heart muscle and time is brain muscle. In your ambulance service that you mentioned, do you guys have Wi-Fi enabled in the ambulance?
Yes, we do. We have Wi-Fi devices that are there through a cellular service in order to transmit those images. And very rare, I would say less than 5% of the time, we do get into an area where it may take us driving for 2 or 3 minutes before it's actually able to submit, because there wasn't service at the patient's home. But again, still reaching that provider much quicker than waiting for our ambulance to get in and assess an EKG. So we have 120 minutes is the goal time to get a patient from over a handful of times. McKenzie has met that, coming from a rural area into an urban hospital. And because of our relationship that we've built with these organizations, the patient goes directly into the cardiac cath lab. There's no going to the emergency department. There's no, I mean, the team is prepped and waiting for the patient in the cath lab when they arrive from McKenzie. So these relationships and partnerships when you're in a rural area are extremely important for your outcomes of your patients.
Very cool. Last call for questions. I'll put that out there one more time. And I wanted to ask you about both chronic care management and remote patient monitoring services. So have you done anything around either of those two, I don't know, billing methodologies is the right way to say it, but with your patients who have chronic diseases?
We do not do any of the remote home monitoring, but we've done chronic care management since we started in the ACO in 2014. So very robust system there. We've, as well as anything else, we've gone through failures and successes. And so our program is very well utilized throughout the organization and the community. It did take a lot of time to get providers to refer, for the hospital to identify those patients, and for patients buy-in as well. I think everything new is buy-in from those, but we definitely have seen some great outcomes from that service.
Great, thank you. Final question. When COVID hit, did you use any incentives to get the providers to jump on the bandwagon for telehealth?
We did not, and I was going to speak to this, so I will just briefly, because I left that out, as we were very fortunate. Our EMR system offered a platform to be able to provide telehealth visits, so I think that was comforting. We had looked at it, as I stated, we'd been looking at it for a couple of years, but really wasn't getting anywhere with saying, yeah, it's time, let's launch the service. And so we were able to turn it on, and patients were comfortable because they logged onto their portal that they were used to getting results from. Providers and staff, it was the same platform they had been utilizing. So we did not have to use any incentives for them. Was your patients are, they're not coming in, patients calling, I think maybe was an incentive saying, are you providing telehealth? Because the provider next door is offering telehealth. And so maybe that was an incentive for them. I don't recommend just jumping in, but in this instance, jumping in got us over that hump.
Mm-hmm. Absolutely. And what electronic medical system do you guys use?
eClinical Works.
eClinical Works, awesome. I didn't know that they had a built-in module for telehealth. That's good to know. All right. I think we are at the end of our time here. Again, in the chat box, there is a link. If you'll click on that link and fill out our post-webinar session survey, we would appreciate the feedback. And Billi Jo, thank you so much for speaking to our audience today. We really appreciate it. You guys have done an awesome job. So congratulations to you guys.
Thank you. Thank you for having me.
All right, take care.